This conference will now be recorded.
All right. Nope. There we go. All right. So my name is Jesse Wren. We're going to go ahead and get started. We're going to start with the journal club aspect first, and then the case presentation afterwards. So the article we're going to go over today is from the Resuscitation Journal. The article is Physician's Presence in Pre-Hospital Setting Improves 1 Month Favorable Neurological Survival After Out-of-Hospital Cardiac Arrest, Propensity Score Matching Analysis of the JAAM OHCA Registry. So the clinical question that's posed in this is asking if the physician presence in a pre-hospital setting would improve favorable neurological survival in out-of-hospital cardiac arrest. Going through the aspects of it, so this is the general overview. The population that was targeted were adults, at least 18 years old, and of medical etiology, meaning that they didn't suspect trauma or anything else related to that. And the treating participation is what we're going to be going for in a little second, where the institutions involved in this registry. And most of the institutions participated were between June of 2014 and December of 2017. They excluded patients whose data was missing, so from their type of EMS documentation or from their hospital documentation. Interventions. So this was essentially the physician response was the intervention. They used a retrospective analysis through the registry. The registry stands for the Japanese Association for Acute Medicine Out-of-Hospital Cardiac Arrest Registry. Sorry, I'm having some issues clicking here. There we go. All right, and comparison physician presence with or without physician presence during out-of-hospital cardiac arrest. The outcome that they were looking for was one favorable neurological survival, and they measured that with the CPC score, 1 being good cerebral performance and 2 being moderate cerebral disability. Secondary outcome was overall 1 month survival. And their conclusion that we'll go over is that they believe at 1 month favorable neurological survivor after out-of-hospital cardiac arrest was associated with pre-hospital physician presence. So why this was being looked at, so in a lot of countries and even within a couple of our own systems here, there's pre-hospital physicians that are integrated into EMS systems. There's been prior studies that have tried looking at this, mostly retrospective analysis, meta-analysis, on whether or not there's improved outcomes with those that are the most critically ill, specifically out-of-hospital cardiac arrest. With that, the measurement would be looking at if there was actually any true effectiveness when those pre-hospital physicians were there. And there's a little of controversy, especially with the limitations of a lot of these studies. And this article had pointed out that a lot of studies don't necessarily include statistical analysis of what happens in the hospital as well. For example, there may be confounders in how the patient was treated, the resources used by the hospital, and just because a patient does better, it may have been associated with what the hospital did and not necessarily what the pre-hospital physician did. So they try to sort that out with their own analysis here. The data collection involved 2 different registries. The first one was the pre-hospital resuscitation data from their All Japan Utsin registry. This is managed by the Fire and Disaster Management Agency in Japan. And this is filled out by either the pre-hospital physician or the EMS agency and uploaded into this their national database. The things that they're collecting are the location of the cardiac arrest, any performance-related times related to the cardiac arrest, whether or not it was witnessed, whether or not there was bystander CPR, whether or not there was dispatcher instructions, and recorded whether or not there was a shockable rhythm for the initial rhythm that was shown, and any outcomes associated with that. The second registry is in the hospital, and this is the overall Japanese registry that we had mentioned earlier. This one has actually been looked at quite extensively as well, and they've done prior papers talking about how this registry was established and what they've been able to do with it. And this started back in 2014. This registry has roughly 295 critical care centers in Japan, and all of them have specialized treatment capabilities, from whether that be ECMO, PCI, balloon pumps, or temperature management. And it's actually interesting, you can go onto their website and they can actually show you, unfortunately all of it's in Japanese, but you can actually see a lot of their documentation that they've done with this registry. The data they've been collecting with this, very similar: the location of the cardiac arrest, emergency call times, patient demographics, along with CPC scores. All right, so for this study specifically, they had combined both of those registries, looking at the data there, and they also tried to add in any causes for cardiac arrest, whether or not the pre-hospital physician was present, and they defined that by being on scene, traveling from the scene, and arriving to the hospital with the patient. They looked at whether or not there was in-hospital treatments, including ECMO, PCI, balloon pumps, and temperature management, and they recorded outcomes with 1 month neurological status and 1 month survival. They mentioned that the neurostatus was tracked by their medical staff. Medical staff at each of the institutions themselves would follow up with the patients after being discharged. Here we have the overall study design. Again, they looked at data from 2014 through 2017. This was over 34,000 patients. And after all their exclusion criteria between non-medical etiology, those who were under 18, and if there was any missing data, that was narrowed down to a little over 19,000 patients. And you can see here at the very bottom, roughly 11% had pre-hospital physician presence, with the remainder 89% without. Here's starting with their first table for the results. This just outlines the time that it took for the pre-hospital physician to arrive and the time for the EMS to make contact as well. The main thing that was pointed out here was that the time it took between a physician to actually see the patient was around 10 minutes, meaning between a pre-hospital physician versus a in-hospital physician, and whether or not that actually makes a difference is something we'll discuss in a little bit, but just interesting to note there. All right, and the second table outlines the baseline characteristics that they were looking at. So you can see here on the left-hand side of the screen, everything from patient demographics to whether or not this was witnessed, if there was CPR, bystander CPR, and if there was a documented shockable rhythm there. The one thing that I want to point out with this study that I thought was interesting, and it's kind of their main part of their study, is that they use this thing called a propensity score matching. And what this kind of did, what they were trying to do was they were trying to take anything that was biologically essential that could be confounders and take that out. For those who aren't familiar with this type of scoring, it's their best way of trying to take a observational study and mimic characteristics of a randomized control trial. And they do that by trying to balance all the different covariables and to make them more balanced between the treated and untreated. This, in theory, should reduce confounders, reduce selection bias. And you can actually see an example here. So without this kind of scoring and matching, you can see that the physician presence only had a little over 2,000 patients and the rest had 17,000, and clearly that's very unbalanced data. And so they essentially took a randomized pick out of those physician presence and absence and try to make that more standardized here. And what that does is this standardized mean on the columns here just goes from things being drastically variable to everything staying under 5%, which makes it more likely that the data is real. All right. so table 3 here takes the same characteristics that we looked at earlier and then separates that into shockable and non-shockable rhythm. And we're going to take a look at this more in this next table here, in table 4. So this takes that data and now characterizes it with the outcomes that we're looking at. So this is the 1 month favorable neurological survival and the 1 month overall survival. So you can see here for the 1 month favorable neurological survival outcomes with the pre-hospital physician seem to be statistically significant for 1 month neurological survival. And the same thing was also seen with overall 1 month survival with physician pre-hospital presence. There was significant survival compared to no pre-hospital physician presence. Same thing we're going to look at if we break it down to that subset of population with the first documented non-shockable cardiac rhythm. Those with physician presence in the pre-hospital setting seem to have a statistically significant outcome for neurological survival and overall 1 month survival as well. And the last part here to take a look at is for those with shockable rhythms that were initially seen. There's actually no statistical significance with outcomes here. And the same thing was for 1 month overall survival. No statistical significance, whether or not the physician was present in the pre-hospital setting. So this leads to our discussion here. So their overall conclusion and discussion on this aspect was that there was a positive association between physicians' presence at cardiac arrest and 1 month favorable neurological survival. They were able to adjust for those in-hospital treatment factors. And lots of thoughts on what this could be and could not be. And the initial thought was that with the pre-hospital physician present, they can provide that extra level of treatment and a little bit more rapidly instead of waiting to get to the hospital. And this could be limited by a lot of different things as well. We had mentioned that it was a little bit 10 minutes earlier between the hospital and pre-hospital setting for a physician to arrive and perhaps to be able to perform a more advanced level of treatment. Japanese EMS, they had mentioned, can't perform tracheal intubations with difficult cases, and they measured that with the Cormack-Lehane classification. I couldn't actually find the specific protocols that they use and what their limitations are, but I imagine with any high level of classification, they wouldn't be able to intubate, and perhaps someone with more experience or perhaps more tools were able to do so. The next thought is whether or not there may have been quicker diagnosis and quicker treatment because of that thought process. And perhaps maybe having a pre-hospital physician on scene could overall guarantee a certain standard of quality of performance that was performed by EMS personnel as well. This data continues to support other meta-analyses that have been done. One of them was actually done with the same registry that was used here in Japan and actually looked at traumatic out-of-hospital cardiac arrest that had similar data for 1 month survival as well. And the last part of discussion was that there was no statistical significance for those with non-shockable rhythms. A possible thought for that was that they had mentioned they allowed easy access to AEDs and had more public support for bystander CPR starting in July 2004. And they attribute to the fact that because of this early intervention and people were being defibrillated and shocked earlier before EMS had even arrived, that there would actually be no difference in whether or not the physician was present because the defibrillation was ultimately what that patient needed. At this time, I'm just trying to hear if there's any other thoughts or discussion from the rest of the group.
Hi, it's Steve Cohen. Question. I'm not sure if this is what you said before, but did they correlate? So it seems like the ones that the physicians were on had a higher index of shockable rhythms, and then the ones that the physicians were on had a higher survival rate. But did they correlate shockable rhythms to shockable rhythms, kind of like they do in the Utstein? You know, when we rank them according to the Utstein model, so that we're comparing apples to apples.
Yeah, so I think that's what they had alluded to with the propensity scoring. When you look at the data that was shown before the propensity score was attributed, it actually looks like it wasn't comparing apples to apples, and you had certain parts of that data saying that with pre-hospital physician presence, there were more shockable rhythms, there were a younger patient population, or there was aspects of the variables that seemed unbalanced. And I think they were trying to use the propensity scoring to say that taking all that data and making everything more balanced, it is comparing apples to apples, and they do think that there is that association.
Gotcha. Thank you.
Mhm.
I'm not sure if you'll be able to answer this, but how were these cases selected? You know, was it they got dispatched? They just heard that there was a patient in cardiac arrest. You know, did they go into that, or is just what the
Are you
registry
talking
got?
about how the physician was dispatched?
Yes.
No, so yeah, that's one of the definitely one of the limitations in that they did not go into that and said that every hospital or every system had a different way they dispatched the physicians, and so they were not able to go really into any detail at all. Just to mention that that was a big limitation. They even had a statistic in there that of all ALS calls that they had, physician presence was in 0.6% of their calls. And they had no good way of knowing how they were dispatched. All they measured was whether or not the physician was on scene, if they and had traveled with the patient, because they were required to sign one of the forms.
Yeah. Yeah, I just wonder. We have one of our former graduates is actually in Japan working right now, and we can actually formulate a couple of these questions and reach out to him and also the authors of this paper and see if we can get some of these questions answered. You know, there's definitely a little bit of bias because the people who are publishing this study are, they're physicians as well. And then, of course, we have to look at how the system is designed. So the system in Japan, it's more of a fire-based system across the country, and then how their dispatch is. And like you mentioned before, that they can't do tracheal intubations for more difficult cases. There's a couple other things that this group actually publishes a lot, and I believe they also attend NAMSP every year. So we may see them in San Diego.
All right. Yeah, they're the same group. Yeah, it's the same group that does all of the registry data with the traumatic cardiac arrest and all of it. Yeah.
There's actually a Southeast Asia consortium of EMS physicians. I'm on it for the Thailand people, but we can try and reach out to them.
Okay.
Anyone else have comments on this article?
I thought it was a good presentation, good data. This is Jamar. My question is kind of related, but not directly related. Do you know if there are increasing trends for physicians to be present in the field? Is that what's going on in Japan?
I don't know the answer to that, actually.
I'm curious because if for someone to be looking at this data, it almost suggests that there should be. If there is this positive correlation between presence of physicians in the field, then it supports the fact that, well, why not put more? So that's where that question comes from. But thank you anyway.
Yeah, I have to imagine so, because I think that's what's happening. I mean, here in this country, there was that, I think, paper that was just sent out to us that was just of this year of just trying to establish clinical roles for physician presence in the pre-hospital field. So yeah, it might be. I have to imagine you're absolutely right. Someone's looking at this because it's actually happening more.
Yeah, and you can't justify anything without some sort of data to kind of push out. The previous data in line with this is that physician involvement in an EMS agency creates better outcomes. Just being present for CME, being present for operations meetings and education competencies, things like that with the staff. Also, I would wonder in this case is when you have a physician just show up to a scene, if no one knows them, they're not gonna, I don't believe it's gonna be as helpful as if they already know the crew, they know the team, they've trained with the team, and then they're just part of the team. I feel like you're gonna have much better outcomes with that than just anyone showing up.
I think when we looked at when I looked at the paper, they were speculating that the possibility of, I guess, improvement of survival was due to reversible sort of like pneumothorax non-traumatic pneumothorax or non-traumatic pericardial effusion and causing tamponade. And I just wonder. I guess they never built, Jesse, I don't know if they built out anything regarding why exactly, like, the physician, like, if there were any physician level sort of interventions that caused sort of this difference in survivability, especially since we have seen, at least in the traumatic data, there is definitely a difference in sort of the very homogenous Japanese patient population versus something like our patient population is very diverse.
Yeah, no, that's a good point. They really seem to like to reference the pericardiocentesis and the intubation. So I'm not, but yeah, they had mentioned the introduction, but that data would have been interesting to see. And that's definitely a limitation here, is that we actually don't know how well the interventions were done and what interventions were done and how much time it took to do these interventions. I did actually try looking at their website. I think after a few of the PDFs, I gave up on that because there's a lot of bad attempt at translation. But yeah, that'd be interesting data to see, and probably that details would be a little bit more helpful too.
I wonder if that is a criteria as part of their data that, we've been talking about, is it witness versus unwitness, shockable rhythms, all those things that make cardiac arrest outcomes better. If they actually have those other additional things in there. And I would assume they do, but we can reach out to Snow and see what he says, because he's in it now. So I don't know if he's part of this, one of these groups, but he should probably have access to their data.
Yeah.
So we'll work on that.
Also a little surprised. I actually would have figured the amount of time it took from, they had said it was about 10 minutes from a patient seeing a physician, so whether that be pre-hospital or in the hospital. In my mind, if the physician was present and it wasn't something traumatic, they would have been staying on scene a little bit longer. So I would have thought that time would have been longer, because that includes the transport time too. So it's interesting it was only 10 minutes.
That could be also their termination protocol. If it's too far out, they might terminate earlier. But again,
Yeah.
unless we talk to someone who's on the ground there, we're not going to be able to suss that out.
Yeah. All right. So the next here, we're just things that we talked about, limitations. Again, this is a retrospective study. So there's a little bit of unmeasured confounders, a selection bias, but their goal in using this propensity score is to limit that the best they can. And then we don't get to know or assess the kind of care provided, like we mentioned. So we don't know the quality of CPR, we don't know the downtime, what kind of interventions are being done. And as we touched on, there's no uniform way to dispatch physicians. So that's definitely, whether it's protocol-based, system-based, a lot of that can vary from institution to institution. And the last thing was that they had mentioned that not all institutions in Japan were enrolled. It seemed like they were a little bit more selective, and I think the government had a role in this too, in that the institutions enrolled usually had some sort of high level of care they could provide, whether that was ECMO or PCI or something special they could do. But they do their best to include everyone in the registry at least.
And even from our own cardiac arrest data, unless you have a good system in place already, advanced level interventions don't help. You can only drain the heart if you've been perfusing the tissue and the brain until you got there. So that's why I think, was it 2015 or 2010 when AHA kind of moved to more focus on good CPR, pit crew CPR, things like that. So that focusing on good BLS, good things like that.
Okay, yeah. Our quality checklist here for observational studies. Did the study address the focused issue? I think so, they did. Authors using appropriate methods to answer the question, I think with the propensity score and the way they analyze their data, for sure. Was the cord recruited in an acceptable way? It was a retrospective analysis, and I think that did well with that too. Was the exposure accurately measured to minimize bias? Again, the propensity score, I think, helped with that. Outcome accurately measured to minimize bias? Yes. Have the authors identified all important confounding factors? I believe so as well. They touched upon it a couple times throughout the paper. Was the follow-up of subject complete enough? This part I left blank, mostly because other than mentioning briefly that hospital staff at institutions followed up with the patients, we don't actually know how that was done or who measured the CPC score. I have to imagine that there was actually involved an in-person visit beyond just a telephone call. So I think that would have been a little bit better to highlight how that was done and how that data got translated over. How precise are the results? I think they were pretty well. Do we believe the results? We do. And can the results be applied to the local population? I had initially said no, just because it's a different system, different country. But at the end of the day, the idea of a physician, pre-hospital physician helping in a cardiac arrest, I think that in itself can still be applied to anywhere, despite whatever protocols that a local system may have. Do the results of the study fit with other available evidence? Yes. And just in general, the external availability and applicability is similar to what I just said. Even though this paper was done in a different country, in a different system, I think the concept of having that pre-hospital physician is still similar no matter what system you're in. So the treatment is still similar. The interventions that can be done are similar, and I think that's still applicable to places like our system where we are out there also responding with the EMS crews. And limitations are also pretty similar. Trying to record how we're dispatched, and if there's a uniform system to dispatch physicians, that's still a pretty big kink that's being worked out no matter where you are. All right. Any other comments, questions?
No comments. Good job.
All right. Thanks, guys. So we'll go on to a case study here. So this is going to be respiratory distress. Is it COVID? I know this topic has probably been touched upon quite a bit in the past as well. And with COVID numbers rising again, I figured we would touch a little bit about respiratory distress in general as well. So our case is going to start with a 65-year-old female, shortness of breath over the last 24 hours with a cough. On EMS arrival, patient's tachypnic, initially 75% on room air, with improvement up to 94% on 15 liters non-rebreather. A little background on the patient: history of hypertension and COPD, no home oxygenation, and was discharged close to a week ago with COVID pneumonia, and this patient is not COVID vaccinated. So right off the bat, some differentials that can be going through our minds, especially in the EMS setting. This is taken out of the NAEMSP textbook. Something we'll be touching upon is just trying to sort out likely versus unlikely for diagnosis. But so for this patient, the first things that would pop into my mind are pneumonia. It could be exacerbation of her COPD versus, since she was recently diagnosed with COVID, a little bit more coagulable, PE would be up there as well. And that's not to say the remainder of the differentials on the list is also likely, especially given her age and risk factors. The interventions that were done with EMS, they provide the oxygen support. They gave a round of Duaneb. Some additional considerations that we'll also touch upon later is perhaps some steroids, with how the patient looked, perhaps starting them on non-invasive positive pressure, and if there was any concern for hypotension, IV fluids could be started as well. So when the patient arrived to the hospital, here we have some initial vitals. 142 over 105, heart rate a little tachy at 103, tachypneic at 26, and pulse ox was now down to 90% on the non-rebreather mask. A quick initial exam showed this patient was alert and oriented, a little tired appearing. The lung exam had crackles, expiratory wheezes. She was tachypneic and using her intercostal muscles with retractions. Heart rate, like we mentioned, was a little tachycardic, but no murmurs, no JVD, no edema. So this patient in the ER ultimately continued to receive DuoNeb treatments. With how this patient presented and how she looked being on the non-rebreather, she was pretty immediately placed on BiPAP. This is her initial BBG. You can see pH is a little low at 7.3. CO2 is a little high at 52, putting on a respiratory acidosis. After about an hour and a half of being on the BiPAP, this was her repeat gas. Definitely shows improvement of the pH to 7.39 and the CO2 going down to 41. She was started on antibiotics. This is her chest x-ray. Definitely not good looking. You have their bilateral interstitial involvement there, probably a little bit of edema as well, and chronically likely has underlying changes from her COPD as well. This patient did also subsequently get a CTA of the chest. I was not able to put the images on, but the impression here, there are no PE, a lot of chronic changes from COPD and some worsening of airspace and ground glass opacity is consistent with pneumonia, with that bilateral appearance, also very likely COVID pneumonia. Patient was ultimately admitted and was actually still in the hospital the last day was able to follow up with, and has had a pretty long course, close to 2 weeks of inpatient admission now. Was weaned down to high flow for a bit, and then weaned down to non-rebreather mask, and then now is weaned down to a nasal cannula. She did get an echo for completion of her workup and did show a small to moderate pericardial effusion with a little right heart strain that appeared to be chronic, but no tamponade physiology. So just going over pre-hospital management of respiratory distress. Now this topic is very broad, so this is just kind of a 360 overview. Each topic in its own could really be its own lecture. Respiratory distress is one of the most common chief complaints. It's second actually in EMS after minor trauma. And actually, if you look at recent call volumes, which a lot of our EMS friends will also attest to, is there's definitely been an increase in the calls as well. And the estimate right now is anywhere between 4 to 5%, and it could be definitely a lot more in certain areas too. The big focus for management is always going to be on the immediate threats, your ABCs, looking how the patient appears overall. And if you can and have that time, trying to think of diagnosis-specific therapy by thinking of their underlying cause. Now, most patients end up being undifferentiated, especially in the pre-hospital setting for respiratory distress. But something always good to think about. The four most common that have been highlighted based on prior EMS data have been upper airway obstruction, small airway obstruction, acute cardiogenic pulmonary edema, and pneumonia. So this fits into our patient's case as well. This essentially puts back the differential list that was on the other slide, just typed out here. Again, always thinking the likely versus unlikely with the patient, and that can change your management a little bit. A few things to highlight. Number one there for pneumonia, has a kind of a double-edged sword with asthma and COPD patients. Those with asthma and COPD definitely have worsening outcomes and worsening mortality with pneumonia, and vice versa. Those with asthma and COPD are more prone and more likely to be diagnosed with pneumonia based on their comorbidities and based on their age as well. Another thing to always keep in mind that I think is frequently put to the side is tox and the metabolic aspect of respiratory distress. We don't probably see it as often, but especially those with DKA or salicylate toxicity, their metabolic acidosis may be triggering an attempted compensation with a respiratory status. Something always to keep in mind as well. So part of your initial management here, assessing and securing the airway, you're putting the patient on the monitor, getting their baseline set of vitals, getting IV access, placing them on an end tidal, and there's constant reassessment. And this can apply to really all EMS calls as well. And a lot of this is happening at the same time. If you can establish that the patient is protecting the airway, your next step is then looking at how they are breathing. And these are some of the main things that to look at and can pretty quickly identify. So if they're tripoding or having conversational dyspnea, can you match that up with the fact that they have a history of COPD or asthma, and that could be their exacerbation? If you're concerned for heart failure and volume overload, you may be able to see JVD, hear crackles, have edema, or if they are a low output state from their heart failure, you may be realizing that they have a cool skin instead of warm. Breath sounds can help identify if there's perhaps a pneumothorax or a pleural effusion that's creating a unilateral sound, and just the overall appearance of how they look, whether there's retractions, if there's trauma. All these are pretty helpful in trying to establish if there may be more issues beyond just the initial assessment. So after the initial vitals and getting that baseline, you want to provide some medication therapy. First one being oxygen as needed. So this is just the oxygen support, no ventilator support yet. The goal being anywhere between 93 to 96%. COPD patients, you may be lowering that down from 88 to 92%. And it's really titrating the oxygen as needed. And there's plenty of studies and textbooks that mention that COPD patients do better with titrated oxygen regimens. It decreases mortality. It allows you not to essentially give them too much oxygen. And here are your different delivery methods for oxygen in most settings here. You have your nasal cannula. The flow there is anywhere between 2 to 5 liters, and your FiO2 is 21 to 40%. The next step up there is a simple face mask that can deliver from 6 to 10 liters, anywhere between 40 to 60% for your FiO2. And the last one here is a non-rebreather mask, which our case patient had as well. That's between 10 to 15 liters of flow, and your FiO2 reaches close to 100%. After oxygen therapy, if the patient still has symptoms, this is where more EMS protocols will continue down the line with bronchodilators and anticholinergic therapies, and this would be your duo-neb treatments through a nebulizer. You could be thinking of steroids and be based on what you carry, whether that's methylprednisone or dexamethasone. If they're starting to still get worse and still having bronchoconstriction and spasms, you can start thinking of additional treatment with magnesium, along with epinephrine and terbutaline. If the concern for respiratory distress is CHF-based or pulmonary edema-based, again, oxygen is the same idea. However, now you're also thinking of nitroglycerin, sublingual, and reassessing every 5 minutes, and along with Lasix. This is as long as their systolic blood pressure remains stable as well. Next steps here, if this patient's oxygenation and ventilation starts becoming an issue, so you're finding signs of worsening distress, you're finding signs of impending respiratory failure, now you also have to start assisting with their ventilations on top of their oxygenation. And so you want that volume of air in and out of their lungs to be assisted as well. The first step one here is non-invasive positive pressure ventilation. And this is contingent on the patient being able to protect their airway, they're having their own respiratory drive, they remain cooperative. And a good way to also assess this is with end tidal and continuous waveform capnography, which all of our groups should be able to be capable of. So here are some examples. Here you have a normal one on the bottom, and the top here you have one with COPD, and you can see that classic shark fin appearance. To review a little bit about what you're looking at here, the point A on the bottom starts the expiration, and you can see from A to B there's that small little incline for the dead space, and then from B to C that sharp incline is exhaling air. D is actually the point of end tidal CO2 value that we see on our monitors. and from D to A is inspiration. So you can see that with COPD exacerbation, that shark fin comes from the obstructive process of their physiology, and they're unable to blow off that CO2 as effective as a normal patient. So this is where non-invasive positive pressure helps them be able to blow that off and helps them with that ventilatory effort. For our EMS crews, they will constantly have CPAP. So that's going to be constant pressure as opposed to BiPAP that can change between inspiration and expiration. The goal is pretty similar though. You're trying to open up those bronchioles. You're trying to increase the recruitment. Because it's that ventilatory support, you're increasing that volume of air exchanged. And in return, you can help decrease the work of breathing as well. This has also been studied quite extensively, both pre-hospital and in the hospital, and it continues to show the same thing. Early intervention with CPAP or BiPAP decreases intubation rates, you have shorter ICU stays, and decreased mortality. If the patient still doesn't do well, you start realizing they're no longer protecting the airway, you have changes in level of consciousness or anything that might put them at a risk for aspiration, you have to start giving them additional support. And that could be inserting an oral and nasal airway, start using a bag valve mask. And this is kind of where it depends on your resources, your support, and how far away you are from the hospital. If you're able to continue bagging them well and you're oxygenating and ventilating well, you can stay with that. Otherwise, you may need to move on to a more definitive airway, and that can be either between a supraclavic device, endotracheal intubation, or surgical airway. And each of those topics, as I was saying, can be a whole separate lecture on its own, but this is the general overview of how you want to approach this patient here. Any questions on this so far?
So why do you think they chose 20 and not 60 or 80 for Lasix? 20 seems like a fairly low dose.
It does. And that's actually, so that's another point of a debate as well. I don't have a good reasoning for it, but I do know there's a lot of debate, especially in the pre-hospital setting, on whether or not Lasix should even be, or any diuretic should really be in protocols. There's some studies that have trying to show that whether or not Lasix is even being used appropriately in the pre-hospital setting, because that then essentially relies on our EMS crews to correctly identify that this is CHF and not something else. And crackles can be really any differential diagnosis, and edema could be amongst of other things. So I have to imagine they chose a small dose so that adverse reaction is less. That was my best guess, but I don't really have a reasoning for why they chose that.
Yeah, so if you have secondary signs of edema, that's definitely points you in that direction. And then the use of pre-hospital ultrasound as well, like whether or not you can see, when you put the ultrasound probe on the chest, you see fluid versus no fluid, or even
Right.
you see a lung point or something like that. I know in children we're more comfortable using it for pneumonia or something like that, but you can even see that as well. But the use of CPAP definitely helps and it prevents people from getting intubated. Some people, once you intubate them, like in the case with the COVID pneumonia, sometimes they become so weak that you can't even wean them off of the intubation. So it's definitely very beneficial for our patients.
So you think that this dose should be higher then, or there should be more protocol to allow them to give more?
Yeah, like if you have secondary signs of like a CHF exacerbation, you should be going with a higher dose of Lasix.
Okay. Yeah, and then that also adds the point you mentioned, that ultrasound, and that's another aspect that pre-hospital physicians can bring for another level of care, to be able to help quickly identify a cause and something to reverse. So yeah, absolutely. All right, and so this just leads to our just overall conclusion here, and steps for respiratory distress. You're assessing threats, you're assessing the need for airway and ventilatory support. A lot of this happening at the same time, their vitals, putting them on the monitor, end tidal, and vascular access. And at the same time, you're also trying to evaluate level of consciousness, really their protective reflexes, their overall anatomy, the environment that you're in that you may need to apply for your therapy. And first one is always going to be early oxygen therapy, titrating that appropriately for the patient. And if you have that time to find an underlying cause or think of an underlying cause, you can redirect that medication therapy. So whether that is with nitro and Lasix or more DuoNeb treatments, that'll help guide your therapy as well. And ultimately, it's a lot of reassessment. And if the patient doesn't do better, it's the next line, which it could be your non-invasive positive pressure, or it may be a definitive airway to be able to start transporting that patient. And these are my references, and that's it. Any questions, comments, concerns?
I'm indeed. Matt, you have anything? Neil, Terry?
I'm good.
Nope, I'm good.
All right. So that's it for Journal Club for in case for this this block. Next block, I don't quite remember the date, but I believe it's in 4 weeks, and should be on everyone's calendar. And then for all the